Good morning, good afternoon, everyone. We will be getting started shortly. Just waiting on a few more participants to join. Thank you all for joining. Okay, I think we have quorum. I'll get us started. Good afternoon, everyone. It's my pleasure to welcome you to today's webinar, which is part of the dissemination of the findings from the Data on Youth and Tobacco in Africa studies. Before we get going, I wanted to mention to everybody that we have English to French interpretation for our participants joining us who would like to benefit from this discussion in French. So just before we proceed and I introduce the panelists and the speakers for today, please could I ask that everybody on the call selects the language that they would like to hear this webinar in. So we have the options of English and French. If you go to the toolbar at the bottom of your screen, you'll see a globe icon written interpretation. Click it and select your language. Otherwise, you will not receive audio for translation to English when speakers are speaking in French. So select your specific language so that you can take advantage, because we do have a panelist who's French speaking as well. So whether you would like to hear this in English or in French, please go ahead now and select. Okay, thank you so much. And another housekeeping issue before we proceed. I would like to ask that everybody uses the Q&A function. We have the Q&A function also at the bottom of your screen in the toolbar. You can select the Q&A function and ask your questions so that when we get to the Q&A section or session of the webinar, we are able to answer your questions. I hope that's clear to everyone. Okay, excellent. Good morning, and it's my pleasure to welcome you. We will be having this webinar today as part of the dissemination of the findings from the Data on Youth and Tobacco in Africa studies. This study was conducted in 3 countries. That's the Democratic Republic of Congo, Kenya, and Nigeria. And the objective of today's dissemination is to present the comparative analysis of findings from across the 3 data countries, and to provide an opportunity for country representatives to share their main takeaways from this study. The agenda today will involve a presentation of the comparative analysis presented by Shukri Mohamed, who is the research scientist at the African Population and Health Research Center based in Kenya. The presentation will be followed by a brief panel session with representatives from all 3 countries. So representing Democratic Republic of Congo is Patrice Melambo. He's the director for the National Program for the Fight Against Drug Addiction and Toxic Substances. He will be representing DRC. We also have Shukri Mohamed, who will be on the panel representing Kenya. Representing Nigeria is Emmanuel Abraham, who is the Assistant Chief Scientific Officer from the Federal Ministry of Nigeria. I will be moderating the conversation today. My name is DaYTA Maka. I'm currently the research lead for the DaYTA program, and I'm based in Lusaka, Zambia. So thank you all for joining today. And I will hand off in the interest of time to Shukri, who can go ahead and share her screen. and we get going with the presentation for today. Thank you, Shukri. Welcome.
Thank you, DaYTA. Can you confirm that you can see my slide?
Yes, we can see a slide. Thank you, Shukri.
Okay. Thank you very much, DaYTA, for that introduction. My name is Shukri Mohamed, and I work for the African Population and Health Research Center, and I'm really happy to have you all here to share with you results from the Data on Youth and Tobacco program in Africa. Today, I'll be sharing comparative analysis of tobacco use among adolescents in 3 countries, the DRC, Kenya, and Nigeria. So this slide just shows the overview of what I'll be presenting today. And I'll go ahead and start with our background slide. Just to give a bit of a background, adolescent tobacco use is a growing concern in sub-Saharan Africa due to the region's rapidly expanding and growing youth population, also increasing exposure to tobacco marketing and weak enforcement of tobacco control laws, all of which increase the risk of early initiation and long-term addiction. Previous studies in the region have been the global youth tobacco programs, which are school-based programs that have been done in a number of countries. So what these global youth tobacco studies have done is that they've collected key tobacco use data in school environments, and they've left out of school adolescents, which is a key population. There are also several other studies that have been done, but because of their different methodologies, it's difficult to make comparison across the countries. And so this is now the first study that includes both in-school and out-of-school adolescents, and it uses a harmonized and validated tools in the 3 countries, thus enabling us to have comparable insights to guide regional policy action. So I'll give a bit background on the DaYTA program before I get started. This was a study that was funded by Development Gateway through support from the Gates Foundation. The study was implemented in the 3 countries. In DRC, the Democratic Republic of Congo, it was implemented by Research Initiatives for Development and SRD Lab. In Kenya, the study was implemented by the African Population and Health Research Center. And in Nigeria, it was also implemented by the African Population and Health Research Center in partnership with APIN Public Health Initiatives and Research and Communication Services Limited. The main objectives of the DaYTA study was to collect country-level data on tobacco and nicotine use among adolescents aged 10 to 17 years. And the specific objectives were to determine the prevalence of tobacco and nicotine use products, and also to look at factors associated with all forms of adolescent tobacco and nicotine use. With regards to the methodology, this was a national level representative survey that was done in the 3 countries. The population was adolescents aged 10 to 17 years, and the eligibility criteria was that each household needed to have an adolescent at least the age of 10 to 17. The sampling design was multi-stage sampling. So in this slide, we're showing that in each of the countries, that there are country-level reports where there are detailed information about the implementation of this survey, and also detailed about the results. But today what I'll focus on is just sharing some comparative analysis across the 3 countries, but there's more details in these reports which are available in the 3 countries. So with regards to products, what we collected in the DaYTA program study was any tobacco or nicotine products. But for this particular presentation today, I'll focus only on any tobacco products, specifically smokeless tobacco products and smoked tobacco products. But in the previous reports that I've shared in the previous slide have more details around all these products that you see on this slide. Let's start with the key findings. So the prevalence, this slide looks at, let me just minimize this tab. Okay, great. Okay, this slide shows the prevalence of current use of tobacco, smoked and smokeless tobacco in DRC, Nigeria, and Kenya. And so for the country, DRC is represented with a purple bar, Nigeria is represented with the blue bar, and Kenya is represented with the green bar. And here what we see is that DRC had the highest prevalence across all the tobacco products. So in any tobacco product, you see that DRC had 11.8%, tobacco products, smoked products, it was 8%, and in smokeless tobacco, it was 5.9%. Similarly, we see that in Nigeria and Kenya showed similar results, but lower rates for any tobacco. So you can see that across all the products. Another important result I'd like to point out here is that smoked tobacco was more common, was higher. The prevalence was higher compared to smokeless tobacco in across the products. So you'll find that there's more adolescents using smoked tobacco compared to smokeless tobacco in the 3 countries. Did this change? No, it's not moving. Okay, and this slide, we're looking at the current use of tobacco, smoked tobacco and smokeless tobacco again, but we're looking by sex. So you'll find that for boys, the green bar represent boys, and girls are represented by the purple bar. And what you see across is that boys had a higher prevalence rate of tobacco use across all the products. So 16.1% in DRC, 7.1 in, 3.2 in Kenya, and 5.4. And if you look at across all the products, you'll find that boys had a higher prevalence compared to girls across all the 3 countries and all the products. In this slide, we're looking at the current use of, again, tobacco, same products by schooling status. And here we're looking at in schooling, adolescents in school being represented by the blue bars, and the orange bars representing adolescents who are out of school. Out of school adolescents had a higher tobacco use compared to those that were in school. And specifically, we see that in Kenya, the prevalence was the highest for any tobacco products, as well as smokeless tobacco products at 15.2 compared to those that are in school. And you can see that in the smokeless, we only had 0.4% of adolescents in school, while out of school it was 15.2, etc. And it's similar for the others. In this slide, we're looking at the current prevalence again for the same tobacco products by age group. And here we represent that the adolescents who are 10 to 12 are represented with the green bar. Adolescents who are 13 to 15 are represented using the orange bar, and the purple bar represents adolescents age 16 to 17. And what we see here is that in DRC and Nigeria, the highest prevalence was among the adolescents in the highest age group of 16 to 17. And you can see that here. And this was for all the products for DRC and Nigeria. However, in Kenya, what we found is that the highest prevalence was among those that were 13 to 15 years of age for any tobacco product and for the smokeless tobacco product. In this slide, we see that we're looking at the prevalence of current use of any tobacco, smoked tobacco and smokeless tobacco. And here we're looking at it by residents, so urban and rural residents. And in this slide, we represent blue, rural is represented by the blue bars and urban is represented by the pinkish bar. What we see here is that DRC had the highest urban prevalence across all the products. So you see that the purple is highest in all the three products. Smokeless tobacco was highest in rural areas of Kenya and Nigeria. For smokeless, we find that the rural was higher compared to the urban. And then in Kenya and Nigeria, again, we see that smoked tobacco prevalence was similar because the confidence intervals overlap, so that the prevalence was similar between rural and urban areas. In this slide, we're looking at factors that were associated with the increased use of using tobacco products. And what we see here is that in Kenya, DRC, and Nigeria, being a boy, being of an adolescents who are of an older age, so those are 16 to 17-year-olds, and adolescents who had members using tobacco products had an increased likelihood of using any tobacco product. And then there were also other specific findings. For instance, in DRC and Kenya, adolescents who observed anyone smoking in school buildings were associated with higher use of tobacco products. In Nigeria, adolescents who are employed, who came from male-headed households and who had teachers who smoked had a higher, who used tobacco had a higher likelihood of using any tobacco. In this slide, we're looking at factors that decrease the likelihood of using any tobacco. And what we found was that in Kenya, having a household head with a high level of education, in Nigeria, having both of your parents alive, and in DRC, having coming adolescents who are from a female-headed household had decreased likelihood of using any tobacco products. So based on our findings, we have a few recommendations to policymakers, and this would be enforcing smoke-free zones, particularly in schools and public spaces, so that the visibility and normalization of smoking is reduced. Also promoting smoke-free homes. In our results, we saw that a lot of factors that were associated included, having a parent who smoked. So promoting smoke-free homes through family-focused awareness and cessation support is also important. And then development of inclusive interventions with specific focus, particularly for boys, older adolescents, and out-of-school adolescents are also important. And so to conclude, tobacco use among adolescents is preventable, but it also requires urgent and tailored action because, as we've seen, there are specific groups that are affected more than others. And then also looking at the country level, there was a variation, so substantial level differences emphasize the need for context-specific and country-specific responses. So the responses in Kenya are likely to be different as from responses in Nigeria and DRC. And lastly, stronger policy enforcement and adolescent-centered strategies are very important to reverse either the growing trend or also trying to also reduce the current trends that we're also experiencing. So with that, I'd like to thank you, and I'll hand it back over to DaYTA.
Great. Thank you so much, Shukri, for that presentation. I wanted to remind everybody about using the Q&A function. I've noted that we haven't had any questions coming in yet. I'm not sure if the function is working as it should be. In case it isn't, please hold on to your questions and take note of them. So those are your questions for the speaker, for Shukri, and for the panel session that's coming up next. Please hold on to those questions, or do attempt to put them through the Q&A in case that will work. So thanks, Shukri, and we now proceed to the next session of this webinar, and that is the short panel discussion with our representatives from the 3 countries. So we have Mr. Mlambo representing DRC, and we have Mr. Abrams representing Nigeria, and we have Shukri representing Kenya. So thank you to our panelists. I think I introduced them and gave their designations at the top of the hour. So in the interest of time, I'll proceed. Each of the panelists will be asked, the first question will be asked to each of the panelists in turn. I'll begin with Mr. Mlambo. I see we have a hand raised. I do see that we have a hand raised. I'm not sure if the person if that's deliberate. But just unless it's something critical, we will have a Q&A session. I see 2 hand raised, so I'm going to pause. I see Sylvan had his hand raised. Are you able to unmute yourself, Sylvan?
Merci beaucoup. Merci à tout le monde.
All right. So to you, Mr. Lambo, the first question that I have for you is, what, if anything, stands out about your data? So that's basically.
Merci beaucoup. J'attendais pour être ici. Et dans, dans ce résultat, je pense que Shukri venait de présenter, vous avez vu que la RDC a une prévalence plus élevée comparativement aux autres pays. Et ça, c'est une grande interpellation et ça nous surprend, puisque vous trouvez entre les 3 pays, ce sont tous les 3 pays africains, mais la RDC a une prévalence la plus élevée et aussi même pour tous les autres produits. Et cela nous surprend aussi en voyant la tranche d'âge, puisque en fait, la problématique du tabac ou de consommation du tabac, c'est un problème très sérieux de santé publique. Et nous sommes très surpris en voyant les plus jeunes déjà commencer à cet âge-là de fumer le tabac et de toutes sortes de tabac, comme nous l'a dit la présentatrice. Et cela nous surprend aussi de voir que c'est chez les garçons, en fait, c'est du sexe masculin qui sont les plus consommateurs. Alors que, vous savez, la production du pays, ou l'avancement du pays, c'est dans cette jeunesse. Donc, on trouve que cette jeunesse est exposée à la plus haute consommation de tous les produits et surtout les jeunes garçons. Donc, voilà les quelques faits qui nous surprennent. Donc, c'est surtout cette forte prévalence par rapport aux trois pays. Et ça inquiète un peu. Et aussi, cette consommation qui a été très, très significative chez des sexes masculins. Et alors que ce sont là les producteurs de demain, c'est ça la main-d'œuvre de demain, et ce sont là les dirigeants de demain. Et donc, on trouve que cette consommation est très inquiétante, largement inquiétante, si j'ai pu me le permettre de dire, par rapport aux trois pays. C'est ce qui inquiète et c'est ce qui surprend dans cette étude qui a été très intéressante, une étude comparative pour les trois pays africains, notamment la RDC, y compris le Kenya et le Nigeria.
Thank you so much. Thank you so much for that response. The next question is fielded to Shukri, and this is specifically around Kenya, the findings from Kenya. So how do the findings in Kenya compare or build on other studies around youth and tobacco use, such as the status of drugs and substance use amongst primary pupils? Shukri, do you have your response to that?
Yes, yeah. Thank you very much, DaYTA, for that question. So with regards to the current prevalence rates for tobacco among adolescents in the current study, it's very similar to the report on the status of drugs and substance abuse among adolescents, school pupils in Kenya, survey that was done in 2019 by National Authority for the Campaign Against Alcohol and Drug Abuse, which is NACADA, in collaboration with the Kenya Institute of Public Policy Research Analysis. The difference a bit is that the current survey was looking at 10 to 17, but that study looked at 18 to 20 years. But what we find is that in the current data study for Kenya, the prevalence was 2.5%, while in that study, the 2019 study, it was 3.2, so the quite comparable. But when we compare to the GYTS, which is a bit outdated from 2013, the current use was 7.8%, which now sort of suggests that tobacco use among adolescents is dropping, and which is very encouraging. This is likely to have been contributed to the adoption and implementation of the tobacco control measures through the Tobacco Control Act of 2007 and the tobacco control regulations of 2014. However, this doesn't mean that in Kenya we should sort of rest and not do anything. We still want to reduce the current burden that we already have, because we don't believe that any child needs to have access to these products. So we'd also like to continue to see a reduction in these advertisements and, you know, exposure for children. Yeah, so thank you.
Thank you, Shukri. So now I'm turning to our representative from Nigeria, Mr. Abraham. I'd like to ask, looking specifically at Nigeria data, what, if anything, stands out? And yes, what do you glean from the insights that have been shared today as they relate to Nigeria? You can go ahead and unmute yourself.
Thank you so much for the question. For Nigeria, one of the facts from the survey that stood out was the age of initiation. And from the study, we saw that kids as low as 5 years were already being initiated to tobacco use. So the age of initiation, we had as early as 5 years, and average age was far less than 15 years. So that's one issue that stood out for us with regards to the survey. Another fact about the survey that is of interest to us is the survey being able to capture kids who are out of school and those in school. Shukri had mentioned it in the methodology, and that's one selling point about the survey, because Nigeria has grappled with the methodology and the issues surrounding GYTS, mainly because we have a huge out-of-school population, and meaning that the GYTS will not be a good representation of the tobacco use status among adolescents. And so that's one good aspect about those survey, that it's been able to capture kids at household level, not just those in school. So those in household who attend school and who do not attend school. And the result has even shown that for some products, there is disparity between those who are in school and those who are out of school, meaning that it's a good way to be able to get the overview of tobacco use among our adolescent population. Thank you.
Thank you so much for that. That's definitely a very interesting insight around specifically Nigeria, the importance of capturing that out-of-school population. Thank you. So I'll move now to the second question. And this is directed first to Mr. Malambo. The question to you today is, how do you foresee using this data and findings for tobacco control policy?
Merci beaucoup, DaYTA, pour la question posée. En fait, c'est une question pertinente, une question très importante, puisque dorénavant, je puis dire, en santé publique, on ne peut pas mener les études sans action. Et quand on mène une étude en santé publique, il faut prévoir des actions. Et là, nous avons une prévalence très élevée. Nous devons entrevoir les actions, des ripostes, des actions qui s'imposent pour améliorer la situation. Et qu'est-ce que nous entrevoyons? Nous, en tant que gouvernement, en tant que ministère de la Santé publique, la première des choses, c'est d'abord d'utiliser ces données pour la planification de toutes les actions de lutte anti-tabac. Vous savez, il y a beaucoup d'années, donc je pense, depuis que la RDC a adhéré à la Convention cadre, que nous étions en train de mener des actions, mais les actions non basées sur les évidences, sur les études, sur les données. Et ici, je trouve que c'est une opportunité, c'est très, très, très important de mener toute la planification basée sur les évidences. Puisque, vous savez, quand on mène une action basée sur les évidences, on répond directement à la réalité. Et ici, je suis en train d'entrevoir utiliser tous les facteurs associés, par exemple, de voir quel est le sexe qui a été le plus incriminé, comme on vient de le dire, et ce sont les garçons. Vous savez, nos actions en ce moment-là, de prévention, par exemple, de lutte, seront dirigées vers les jeunes garçons, et ainsi de suite. Donc, nous entrevoyons lancer la riposte qui est basée sur les évidences et surtout d'utiliser ces données pour toutes les planifications qui vont suivre au niveau du pays. Et cela, je voudrais même inviter ici puisque c'est une très bonne occasion, tous les partenaires impliqués à la lutte anti-tabac en RDC, comme nous avons ces données ici, nous avons l'orientation claire, scientifique, puisque ce sont des données qui ont donné une lumière par rapport à la lutte. Et vous voyez, ici, on ne peut plus tâtonner, on ne peut plus mener des actions comme au pifomètre, hein, comme on dit parfois à l'américaine, frapper partout. Non. Ici, on doit mener des actions qui sont ciblées, des actions qui sont orientées sur les évidences, des actions qui sont orientées sur les données. Et je pense que nous allons bien mener les actions au niveau du pays. Voilà ce que j'entrevois faire. Et le PNLCT, en tant que programme du gouvernement, va vraiment accompagner ces actions-là et donner, vous savez, au niveau du ministère de la Santé en République démocratique du Congo, je l'ai dit tout haut, il y a une très bonne organisation. Nous avons un PNDES, c'est le Plan national de développement sanitaire, et souvent on demande au programme de décliner les plans d'action opérationnels, puisque chaque année, le PNLCT est en train d'élaborer un plan d'action opérationnel. Eh bien, cette fois-ci, la déclinaison du PNDES ou la déclinaison par rapport au plan d'action opérationnel doit être basée sur ces données d'une étude importante comme celle-ci.
Thank you so much for that response, Mr. Malambo. Great. So the next question is fielded to you, Mr. Emmanuel Abraham. The question is the same as that was previously asked, and that is, how do you foresee using the data of findings specifically for tobacco control policy in Nigeria?
Thank you so much. This survey is eye-opening for us in Nigeria. And anyway, unfortunately, it has not been launched in Nigeria. So a lot of the publicity, a lot of the awareness had not been carried out about the result of the survey, and we hope to do that as soon as possible. But what we've learned out of this, one is the need to carry out tailored advocacy, tailored school-based and community-based interventions. It can't be a one approach for urban and rural kids. Of course, we're seeing smokeless tobacco being used more in the rural areas than in the urban areas. And we're also seeing increasing prevalence by age. And so interventions has to be tailored by gender, by age, by urbanicity, and the likes. And also one key aspect is the need to strengthen enforcement, because our law that these provisions in our laws are being flouted. So there's the need to strengthen enforcement arm. There's the need to have more engagement with our law enforcement agencies. There's the need to take these findings to the grassroots level. There's also the need to increase surveillance and monitoring process, because for us, this is like a baseline. We want to see what happens 2 years after. We want to see what happens 5 years after, using these findings as a baseline. And also policies. We want to see policies from Ministry of Education. What are we going to do? How are we improving the curriculum? How are we ensuring teachers are not using these products? How are we ensuring that tobacco-free clubs are established in the various schools? How are we working with youth-based organizations to reach the different aspects of our population? And so these are key takeaways from this survey that we feel when we work on, we will improve the prevalence, but will reduce the prevalence of tobacco use in our country. Thank you.
Thank you very much to all three of our panelists for their questions, for fielding those questions. Thanks. And we will now move to the next session, which is the Q&A. So we have about 15 minutes of questions. And I'm hoping that we can answer first all the questions that have been asked in the Q&A. Thank you to all of you who have asked your questions. And then we'll open it up to the floor. And I would ask that you indicate by raising your hand if you have a question, and I can call on you, at which point you can hopefully unmute yourself. If anybody has any challenges unmuting themselves or is facing any technical difficulty, please, I ask that you use the chat function or that you ask your question within the Q&A. That's my submission for today. So thanks, everyone. We'll get started with the first question that was asked, and that was asked by Caroline Mutai. And the question was, did the pricing of tobacco products matter? So I think this is a question to our speaker. So that's a question to you, Shukri. There's a question on pricing and whether that was something that we were able to ascertain from this study, whether the pricing of the products mattered, and whether that was established through the study. There was also a question somewhat related to this, which I will ask them together. Maybe they can be answered together. And that is, where did the children get the money, and are they aware of the health consequences? So it's a question around if we know where the children are getting money to purchase these products, and whether we collected data on awareness of the health consequences. So those questions, I think that's like three questions, but interconnected somewhat. And those are directed at you, Shukri. Please go ahead.
Yeah, thank you very much for those questions. So the first question that's looking at where, for the pricing, in the study that we conducted, adolescents mainly reported, obtaining these products from friends, someone else, or mainly by purchasing some of these products themselves. In terms of pricing, we didn't ask a specific question on whether pricing was appropriate for them or not. But with regards to where they were getting this money from, the adolescents in the study also reported us getting pocket money. And also there were some adolescents who are also employed. So that was also another avenue of how they were able to afford and pay for these products. And then the other question was around knowledge, right? Yes, in the study. So if I can speak specifically for the Kenya results, about 44% of the adolescents reported that they had high knowledge of tobacco myths and the health consequences of tobacco. But then that also leaves another higher proportion that were not actually answering those questions correctly. So which means that the awareness of the health consequences also needs to be strengthened, probably across countries, but that was specifically for the Kenyan context.
Great. Thank you, Shukri, for those responses. If anybody has questions, please just take note. The Q&A is open, and you're also welcome to raise your hand and ask the questions, and I will add you to the queue. So thanks for those responses. We'll now take the next set of questions, which I think will be best placed to be answered by Mr. Abraham from Nigeria. So these questions were asked by Iboro Henry, and they're around community engagement and strategies around community engagement by the government. The first question is there a collaboration between community-based organizations and the government to raise awareness on tobacco use among adolescents in Nigeria? That's the first question. Then the second, also related, is what recommendations came out of the Nigeria-specific data in terms of improving prevention strategies, especially for hard-to-reach communities? So that's another question around prevention strategies, specifically for hard-to-reach communities. And the third question is, how can religious institutions be better engaged as partners, not just moral voices, but active platforms for youth tobacco prevention and early detection in Nigeria? So I don't know if you've made note of those questions. Saber, maybe you could give us your thoughts and reflections on those.
Okay, thank you so much, Iboro, for those questions. I would try to answer as best as I can to all the questions you've asked. The first is relating to engagement with the community-based organization. Firstly, I would want to put out a disclaimer that Nigeria is a federal system, meaning that there is the tier of government, the federal, the state, and the local government. However, we are working from the federal system. We are working to ensure policy and direction of government is being put in place to adequately address the issues we are seeing. And one of these is engaging the non-communicable diseases DEX in all the various states. And there are some of the states we've been able to go to all the geopolitical zones. And what we do is we don't only engage with the non-communicable disease DEX, we call for sensitization meeting. We've had meetings with traditional rulers in different geopolitical zones of Nigeria, because the information, the awareness, the sensitization cannot just be at the federal level. And so there's a lot to be done, of course, but we've started. We have a communication strategy that we've put in place that will drive communication, that will drive awareness creation, and will drive engagement with not just the traditional rulers, but even with the religious organization. And this communication strategy, we've also given to these various states to implement in their various states. As part of preparations for this survey also, we had met with youth organizations, we had met with religious organizations, not just religious organizations, youth bodies in the various religious organizations. For example, the youth wing of the Christian Association of Nigeria, and also the youth wing of the Muslim Islamic body in Nigeria. These are ways to ensure we engage with the grassroots level and with the religious bodies to pass across this message, not just in sermons, but through collaborations for several sensitization meetings to ensure they know the dangers of tobacco. I think a lot of time, youth, they don't get to know about the dangers early enough. And if they get to know about the dangers early enough, we'll see a lot of deterrent in the use among our younger population. With regards to the hard to reach and the communities, I think the best approach for the hard to reach is to ensure that we awareness through the media. For the local population, it might not be the internet. It definitely has to be maybe with radio or with the community leaders. So these are some of the things we've clearly outlined in our communication strategy that we just started implementation last year, and we're working with several partners to design design jingles, to design awareness materials through IECs and even social media materials to reach the different strata of our population. And there's a lot to be done, of course. Nigeria is a very big country. There's a lot to be done. That's why at every opportunity we get to, we engage with our partners and the various organizations we have working in different aspects, in different areas of the country. We try as much as possible to engage them to see how we can reach every aspect and every sector of the nation. Thank you.
Okay. Great. Thank you so much for that response. We still have like maybe about 5 more minutes of Q&A. I'm going to try and tackle some of the questions coming out of our chat. Thank you to everybody who's participating actively. I'll make note of a few comments, which I don't think I've taken note of, don't necessarily require response, but definitely some acknowledgement. I think there's general sentiment around the importance of awareness and community dialogue around this. I see a comment just coming in from Benjamin around the need for awareness and community dialogue beyond policy papers. There's also a sentiment, and I think this is targeted to Nigeria, that the Federal Ministry of Health, down to state and local authorities, and in collaboration with nonprofits working in the NCD space, needs to make positive impacts related to the issue of tobacco. I think there was also some sentiments as well coming from Kenya around, and this is from Catherine. Thank you all for this awesome presentation. What is the best channel to follow to ensure that both public and private sectors are greatly involved in creating awareness, especially to the grassroots level? I think that's actually a question targeted at Kenya. We have Shukri representing Kenya. I'm not sure if you're best placed to answer that question. I think it would be better answered by someone from the ministry. But Shukri, I'm not sure if that's something you'd want to quickly
What
respond
was
to.
the question again? Sorry, I didn't get the question.
Okay, so I think the question was just around what are the best channels to ensure both public and private sector involvement in creating awareness up to the grassroots level. If you have any reflections on that.
So there are youth organizations, advocacy organizations that can actually be the key. There can be the people that you work with the research that we found to see how that can be bridged in terms of what channels can they have, how can we involve them? There's also another comment here from someone who works in the youth space, who has also commented on how it's important to involve youth in some of these advocacy works, particularly in creating a lot of awareness around these products.
Okay, that's great. Thanks. And I see that some of our panelists are actually going ahead and also responding to some of these questions. A question by to our Nigerian panelists who's answered quite a few questions around the steps being taken to control the sale and use of tobacco amongst children. So that he's responding to that directly. And then there's an interesting question here around in the 3 countries, how far is the approach of smoke-free area? So basically the smoke-free intervention, how far has that gone in all 3 countries? Would someone be able to give us an overview? Maybe I can ask, since you're already in view, Shukri, you could answer that maybe for Kenya around the conversations around smoke-free, if that has progressed, before I turn to Mr. Malambo.
No, I'd actually want to, maybe that would be better placed if we had someone from the ministry to answer that in terms of smoke-free. But a lot of spaces around Kenya is smoke-free, particularly in public buildings. We have a lot of smoke-free areas. So, and I also believe it's schools are also smoke-free, but in our survey, we were also able to catch that maybe those smoke-free policies are not being enforced in certain areas. Yeah, so that's what I can say.
Thank you so much for that. So I think there are a couple of set of questions as well that I'll ask Mr. Malambo from DRC, specific for him. There's a question and a hand raised actually from Chukoi Chapala around why the prevalence rate is so high, and is it because of weaker tobacco control policies, and how will the survey help in fighting smokeless tobacco use, especially in rural areas in Nigeria? Okay, so that it's a 2-part question. So maybe the first part around the prevalence rate for DRC, I'll ask you, Mr. Milambo, to just see if you have any reflections very quickly, because we are running a little bit short of time. I also see that Chukoi Chapala has his hand raised. If you're able to unmute yourself, if you'd like to add to that question, please go ahead. Just give me a second. I think I need to just allow you to talk. Okay, you can go ahead, Chikoi, and add or expand on your question. I think you've been granted permission to talk. So if it's something you want, if you had to add to your question, please go ahead. If not, I'll turn to Mr. Mlambo to respond to the question around why the prevalence is so high compared to the other countries for DRC.
Oui, je voudrais remercier celui qui a posé la question et merci beaucoup puisque c'est la question légale hein, que nous nous posons tous. Mais d'emblée, dans votre question, vous semblez déjà donner quelques réponses. Quelques réponses puisque vous avez parlé de la faiblesse de la politique et la faiblesse au niveau des méthodes de communication pour le changement des comportements, ou en fait de la sensibilisation, comme on l'a dit dans d'autres pays. Et ici, je peux dire que c'est évident, hein, cette prévalence très élevée. Pourquoi? Puisque en République démocratique du Congo, il n'y a pas eu encore une campagne spécialisée, générale, sur la lutte anti-tabac. Non, il n'y a pas eu de campagne. On a des sensibilisations sélectionnées à la radio, à la télévision, et c'est souvent à des occasions comme la célébration de la journée mondiale sans tabac, mais on n'a pas eu des sensibilisations très spécifiques, très élaborées au niveau du pays. Ça peut être la cause. Mais ici, il faut signaler aussi que le pays a bien sûr eu l'arrêté 041. C'est un arrêté de 2022 qui interdit la publicité, le parrainage, ainsi que le fumage dans les lieux publics. Mais c'est un projet qui n'a pris que 3 provinces. Or, la RDC a 26 provinces. Et ce projet-là a pris, avec l'appui des MSH, hein, toujours dans le cadre d'appui au gouvernement, mais c'était pour la ville de Kinshasa, pour le Congo central et pour le Haut-Katanga, qui sont les provinces qui ont été ciblées. Mais on n'a pas mis en place un grand nombre d'espaces non fumeurs, même si ces provinces ont été appuyées. Donc, il y a beaucoup à faire sur le plan de la communication pour le changement des comportements. Et nous pensons maintenant, ce que nous allons faire, c'est mettre en œuvre à l'échelle, hein, à plus large échelle, cet arrêté-là 041 pour que nous puissions vraiment atteindre tout le monde. Voilà. Et aussi, peut-être associer les politiques.
Mr. Malabo, I am so sorry to have to cut you short. Unfortunately, in the interest of time, I'm so sorry. Yeah, I'm so sorry to have to cut you short, but we're definitely running out of time. But thank you so much for those insights. I think that was quite an elaborate response to what was, I think, a lot of interest around the issues that you're discussing. So what we could maybe also do is after this webinar, the conversation can continue, and we can share or put you in touch with the person who specifically asked that question for you to get in communication and see what collaboration can be fostered from that. So thank you all. We are almost at time, and I'm aware that everybody, some people may have to drop off following this call. So I would like to just leave an opportunity to just say thank you to everybody. I'm aware that there were some questions in the chat that we did not have an opportunity to ask, but I think many of them have been answered directly by the panelists. We will go through the questions, and for anything that was not answered, we will follow up and make sure that you receive your answer after this webinar. I think particularly there was a question, there were some questions around illicit trade. There was some questions around the prominence of new and emerging tobacco products. So those, I think, are very interesting insights and very interesting questions, some of which can be answered in this study and some of which can't, and we'll definitely follow up. I also wanted to make note that in the chat, we have provided you with some links to the TCDI dashboard where you can get more information on the findings of these studies. I think the Kenya and the Nigeria pages have been shared, and we will also share the DRC page as well shortly. So this is by no means the end of this conversation. In addition to this webinar, there will be other dissemination events in each of these countries where we'll have more detailed discussion at the country level of the findings, and we'll have an opportunity to interact with policymakers as well. So thank you all for your very active participation today, and thank you to the speaker and panelists. Really appreciate you providing your insights and being able to join us here today. Yes, thanks to everybody. And on my end, I'm really happy to see all the active participation, and I look forward to this conversation continuing. Thank you, everyone. That brings us to the end of today's webinar.
Thank you, DaYTA. Thank you, everyone. Bye-bye.
Merci. Merci beaucoup.